Imagine waking up one morning and realizing that everything you've believed for decades about cancer screening might be wrong. For years, we've been told that early detection saves lives. Simple, comforting, logical. But what if one of the biggest prostate cancer studies ever conducted suggests something far more complicated? What if screening detects cancer, increases diagnosis, leads to more surgeries, more biopsies, more lifelong complications, yet doesn't actually reduce the number of men dying? Today, we're diving into one of the most controversial topics in modern medicine. Does cancer screening actually work? The answer isn't just surprising, it's deeply uncomfortable. In the USA and UK, where this channel's community is based, the belief in screening has been almost religious. Men hear PSA test and think, catch it early, beat cancer. But the reality scientifically, clinically, and emotionally is far messier, and honestly, a lot more human. The word cancer instantly triggers fear, paralysis, urgency, and the feeling that treatment must begin immediately. But medically, not all cancers behave the same, especially prostate cancer, which ranges from slow, harmless forms that would never affect a man's life to aggressive types that spread fast. The tricky part? Screening detects all of them, the harmless ones and the dangerous ones. And once a man hears the word cancer, even if it's harmless, he feels compelled to treat it. This leads to the biggest hidden problem in men's health: overdiagnosis and overtreatment. And the PSA test is right at the center of this chaos. PSA is incredibly sensitive, but not specific. It tells you something is happening, but not what. PSA rises because of age, inflammation, infections, cycling, even sex. So when PSA rises, panic rises, leading to biopsies. Biopsies lead to complications: bleeding, infections, erectile dysfunction, urinary problems, lifelong anxiety. And yet, most biopsies find cancers that never needed treatment. This is where the giant prostate cancer study shook the world. Hundreds of thousands of men followed for years, screened versus unscreened populations. The result? Screening identified more cancers, but the number of men dying barely changed. More diagnoses, more surgeries, more treatment, more suffering. But not fewer funerals. That finding forced researchers to ask a painful but necessary question: are we saving lives, or are we just treating numbers on a test? Overdiagnosis is the hidden enemy. A man gets diagnosed with a cancer that would never have harmed him, but the emotional weight of the word pushes him into surgery or radiation, even when doctors say it's safe to watch and wait. And the consequences of aggressive treatment are devastating. Erectile dysfunction, urinary incontinence, relationship strain, depression, loss of masculinity, loss of confidence, financial stress. These effects aren't rare, they're common, and millions of men in the USA and UK have been affected by unnecessary treatment. This is why the medical community has shifted from screen everyone to screen smartly. The big study doesn't say screening is useless, it says blanket screening doesn't deliver the benefits people assume it does. Instead, targeted screening does. High-risk groups benefit enormously. Men with a family history, African American men who have higher risk, men with BRCA mutations, men with rapid PSA increases, men under 65 with aggressive symptoms. These men must be screened. But mass screening? It causes more harm than good. And this brings us to one of the most misunderstood concepts in cancer medicine: survival rate confusion. When you diagnose more slow, harmless cancers, you inflate survival statistics, making screening look successful even when it hasn't saved lives. It's a statistical illusion. If I catch 10 harmless cancers that never would have killed anyone, and I treat them, all 10 look like success stories. But none of them needed saving. It's like rescuing turtles from imaginary tigers, then congratulating yourself for saving them. This illusion has dominated public understanding for years. And doctors rarely explain it because explaining it takes time, nuance, and emotional sensitivity. But that's what we do here on MedLogic. And that's why we need to talk about the biopsy cascade. Elevated PSA biopsy complications, fear-driven treatment. Up to 70% of biopsies find low-risk cancers, cancers that don't need immediate intervention. But once a patient hears cancer, fear takes over. Even if doctors say, this is the type you can watch, patients feel pressured to treat it anyway. And that pressure leads to overtreatment, one of the biggest hidden epidemics in men's health. Tens of thousands of men have undergone unnecessary surgeries. Countless others face lifelong side effects that affect relationships, marriage, mental health, physical confidence, and daily functioning. Many men don't talk about these complications, they suffer silently, and yet these decisions often stem from a cancer that never threatened their life. Meanwhile, aggressive cancers, the real threats, absolutely must be caught early. These are the cancer screening was meant for. These are the men we need to help with precision screening. But mass screening? It drowns the system in harmless cancers, blurring the line between who truly needs help and who doesn't. And the USA and UK systems approach this differently, yet with similar problems. The USA often encourages more testing because of insurance and commercial incentives. The UK's NHS is more conservative, but still inconsistent in communicating risk. Both systems struggle to balance saving lives with avoiding unnecessary harm. Thankfully, the future is brighter. Screening is evolving fast. We now have MRI-first screening, which is far more accurate, PSA density measurements that reduce false alarms, AI imaging that identifies dangerous cancers with greater precision, genetic and BRCA-based risk scoring. And active surveillance, the idea that low-risk cancers shouldn't be treated immediately, is becoming the global standard. This shift could prevent millions of unnecessary surgeries in the next decade. For men watching in the USA and UK, the best approach is simple. Don't fear PSA, understand it. Don't rush to treatment, ask questions. Ask your doctor directly, is this the type of cancer that will harm me or the type we can safely monitor? Get second opinions. Consider MRI before biopsy. Know your personal risk factors, family history, genetics, ethnicity, and never let fear make your medical decisions for you. Medicine should be evidence-driven, not anxiety-driven. And that's the entire point of this massive prostate cancer study, not to stop screening, but to make it smarter, safer, and more personal. If this video changed the way you think about cancer screening, then this conversation matters. That's why I created MedLogic, a place where complex medical science becomes clear, where myths are challenged, and where truth replaces fear. So before you go, and before we dive deeper into more medical topics in upcoming videos, make sure you support this mission. Please subscribe to MedLogic, turn on notifications, and share this video with someone who needs real science, not confusion, not fear, not medical marketing. Here on MedLogic, we don't just talk Medici,